The first thing that we should take note is breast is an accessory sweat gland. And as we know, glands have got too many parts. For every gland, there is a part that is going to be producing what that gland produces, and then there's going to be a way that is going to be conducting the product. So this part that produces what the gland produces, this is known as the secretory portion. And for the breast, it is in form of acini. So it is the acini of the breast. And then we have got this part that will be conducting the product, that is going to be the excretory portion, because that's the part that you're using to push things away. And for a breast specifically, these are going to end up draining at the nipple. Okay, so these are the two parts. Now, the excretory portion is also known as the duct, the path that you are using. So, specifically, let's mention about the breast so that we see how they start. So, you are going to have a lot of acina. So, let's start first with, say, here is our breast there. And we know the breast is attached on the pec major on the chest. You are going to have these parts that are opening at the nipple, about 6 to 10 of them opening at the nipple, and then they'll be going like that. As they go, they are making the, let me start the drawing from where we are, where the breast is beginning. So let's start from here. What you are going to see is that you have got acina like that, and a lot of these are going to come and form a duct. And then you are also going to have another group of these acina. They are also coming to form a duct. These ducts, they are furthermore going to join to form a bigger duct. And you are going to have a lot of these, not just these. And then before they can open on the nipple, they are going to have a dilatation at the end, and then they'll be able to open. So you're going to have like 6 to 10 openings there. So this one alone is known as a lobule. A group of lobules will make up a lobe. So that's why I'm going to hear of intralobular, meaning inside the lobule, and interlobular or interlobar. So this is between lobes, this is within the lobules. We are going to understand that. So the dilatation before you open on the nipple, this is known as the lactiferous sinus. And that is what we are seeing here. So you can see we are going to have a lobe, but can you see that a lobe inside it has got small structures? Are you able to see those? Those are lobules, and then those lobules are going to come and join, and then they are going to be able to form this big duct, the lactiferous duct. Before the lactiferous duct drains on the nipple, there's a dilatation there, which is a lactiferous sinus. So it's important to understand that, because the actual lobules is where you are going to have the production of milk, and we call that as the terminal duct. Look at this. You have got a big duct. You have got this big duct, and then you have got these small ducts that are going into the lobule. So these small ducts together with the lobule, We call that as the terminal duct lobular unit. So it is actually on the terminal duct lobular unit that we are having the production of the milk. And most of the cancers are actually going to start just there. So that is important for us to know. So as a basic structure, before I start to ask us to make some contributions, and in case we have got other questions to be able to contribute, the basic structure of the breast, we are we are having two major structures of the breast, two major structures. So of those structures, what we have is the duct and also the lobule. These are the major structures of the breast. And then we have got two epithelial cells or two types of epithelium. Anyone that can mention the types of epithelium that are present in the breast? Thank you so much. So lining these ducts and the acini, we know this is a lumen. So we are going to have the luminal epithelium. But what happens is this. Say a woman has a child and the child is suckling. They are stimulating the nipple. And this is what happens also when anyone is suckling your nipple. So that's why they advise don't allow anyone to start suckling the nipple because milk can start coming out, even if it's the boyfriend or something like that. So what is happening is that prolactin is causing milk production. But then there's another hormone released from the posterior pituitary gland, oxytocin. So we have got like smooth muscles here, malepithelium. That helps in contraction to push the milk. So prolactin helps in production of milk, oxytocin helps in pushing the milk so that it is produced. So the types of epithelium, we have got the luminal epithelium, which is making up the lumen, and then we have got myoepithelium, which is basically a combination of epithelium and smooth muscles that will be helping to push the milk. And then we have got two types of stroma. We know stroma is basically supporting tissue. And for the supporting tissue, we have got inter between the lobules. So we have got interlobular and then intralobular. So the connective tissue within the lobule is intralobular, and then between lobules, that will be the inter. We can see we have got this connective tissue between lobules, that is the inter, and then just within the lobules, that will be the intra. That is important for us to understand at least. So now let's say someone has got a disease of the breast. Allow me to ask, how do we think someone that has got disease of the breast is going to present? Anyone that can help? Imagine someone has got breast disease. How are they going to present? Or how will you tell that this one has breast disease? Thank you so much. So we have got one, which is pain. Anything else? Dimpling. Thank you so much. Anything else? Also discharge. We can continue mentioning anything. discoloration, all those things, the D's, right? The 7 D's. Yes, we can continue. Anything else? They can also present with a lump. Anything more? Even a mass, right? Yes, a discharge, including also a mass. Now let's just talk a bit about these presentations. So if we start with pain of the breast, that is known as mastalgia. And for the pain, it can present in two ways. You can have pain. Yes, please. Is that a hand? So the pain can be diffuse or it can be localized. The meaning of diffuse is that you are not just feeling the pain at one point. And normally, when you're talking about diffuse pain, the pain where you are feeling pain not at only one point, this is going to be associated with cyclic menses. Now we know that menstruation happens on average every 28 days. Cyclic with menses. So what is going to be happening is that every time there is this cycle, the patient is having that pain in the breast and just some other parts. Okay. So what would be the cause of this? It is because of premenstrual edema. So before the menstruation, someone tends to have edema. There is accumulation of the fluid, and that can cause pain because of the hormones which are being produced. And then for the localized pain, this kind of pain is going to happen, and it's not cyclic. It doesn't happen with the menses. It can happen anyhow. One thing that we need to know is that almost all painful all pain that is going to be recognized or that will be felt with the breast, mostly it is benign. Please take note. Majority of the pain felt on the breast is not malignant. It is benign. Most of the malignancies of the breast, the cancer of the breast, will present painless. That is why it is going to be identified a bit later on when it has become worse. Okay, let's first talk about discharge. Anyone that can say just anything that they know about the discharge with breast disease, just anything. Thank you so much. So the discharge that is coming out of the breast can be milk, it can as well be blood, or it can just be like liquid, which is like water, and we call that serous. Now milk, when the milk is coming out of the nipple, this is not always associated with malignancy, right? This is, of course, the milk discharge is referred to as the galactorrhea, and it is just because there is an increase in the production of prolactin. You know, prolactin causes milk production, right? And we have said it is not always malignant. But then, what is going to cause? What do you think can cause an increase in the production of prolactin? Remember, prolactin is produced from the anterior pituitary gland. So, what are some of the things that can cause the production of prolactin so that we can have a discharge of milk from the breast? Anyone? Anyone to help? Imagine someone has got a tumor or of the pituitary gland. So that can cause overproduction of the stimulating factor for the production of prolactin. So one thing that can result to increase is pituitary adenoma, and besides the pituitary adenoma, also those who use contraceptives, and also maybe you have got someone that is depressed, so they are using tricyclic antidepressants, contraceptives. All these can cause excess milk production. Okay, and then when it comes to the blood and the serous, these are mostly common when you have got a papilloma. So a papilloma is where you are having structures like this forming like fingers. That's the meaning of papilloma. So in the breast, you have got finger-like processes. Those are papillomas. Okay. So and more they are more common because due to large duct papillomas or cysts. What will mostly cause the production of serous or blood? It's a large duct papilloma. And these papillomas that affect large duct or even cysts are basically fluid filled sacs. So we can see that this is a large duct. Especially here, can you see that the lactiferous sinus is a much larger duct? So the large duct papillomas are mostly affecting the lactiferous sinuses. Okay, so that's it on that one. And when you look at these large duct papillomas and cysts, or even these discharges that are happening, the risk of these discharges, if you see these discharges, the risk of having cancer later on with these discharges will increase with age. So the older someone is and the more the discharges you are seeing, the higher the risk of having cancer. Okay, and then we can also have a lump. Now this lump you can either have or not have a change on the skin, like you can see skin pigmentation or not, plus or minus skin change. Okay, you can also have, of course, masses. So these are some things that someone that has got breast disease will be able to present with. Okay, and the breast mass, the most common lesions when you're talking about breast mass, they are going to be cysts. These are you are feeling a mass in the breast. That's basically a a structure that is filled with a fluid. That's a cyst. But the most common of these masses, we have got fibroadenomas. Fibroadenoma. And then there's also invasive carcinoma. We are going to understand what invasive carcinoma is. So these are the masses that we are able to see in the breast. Okay. So when it comes again to masses, of course, these masses you can palpate them. Most of those which are benign, they are going to be common before menses. Before menses. Actually, not really menses, but before menarche, before you stop the menses. Most of the masses that you are going to be able to see are benign, they are not cancerous. And when you again look at these tumors of the breast, most of the masses, when you look at the breasts, you know a breast can be divided into quadrants. Let's say this is the medial aspect, this is the lateral aspect. So you have got this quadrant. It is the upper, outer, because the lateral aspect is the outer aspect. So that's where the malignancies are more common. about 50%. And then the other masses are going to be the other region where these masses are more common will be on the areola, that will be 20%. And then the rest of the quadrants, they have got a 10% chance of having these malignancies. So it's important also that we take note of that. Upper, outer, followed by the areola, and then the rest of the other quadrants. Is there any other contribution or question before we move on? I've seen a hand from Doc Jackson. Any contribution? Okay. Now, when you're talking about, yes, please. Okay. Are others able to see my screen? Okay, thank you. Maybe it should be the network, or there are only two reasons. Network, it might be slow, or maybe the bundles are a bit fewer. So, any one of those. But you can just try to disconnect and then connect back. I think it will be okay. Okay. So now we can talk about the problem. So when you're talking about the diseases of the breast, you can talk about inflammation of the breast tissue. You can talk about benign lesions, and then the malignancies. We're going to find the cancer. So these are the three things that we are talking about. Then we are done with the breast pathology. So starting first with the inflammatory conditions. Let's start with that. Inflammation of the breast. So talking about inflammation, anyone that can help, what are the possible any cause that can lead to inflammation of the breast? Any cause that we know? Trauma to the breast. Thank you so much. So that is one cause, trauma to the breast. Anyone else? Imagine someone just ended up uh, by mistake, or maybe in a fight they hit the breast, so that will cause trauma. Anyone else? Oh, thank you so much. Also infections, yes. So infections, besides that, there's also autoimmune diseases, right? Where the body just starts fighting its own tissue. Autoimmune diseases. Now, one thing that you need to know about inflammation of the breast is that it's not that common. It is less common. And there are different types of these inflammations that can happen to the breast. Number one, you can have acute. We know inflammation ends in itis. So, breast mastitis. So, acute mastitis, that is the first thing. And then number two, we can have what we call duct ectasia. And then number three, we can have what is known as a granulomatous mastitis. Anyone that can say anything about acute mastitis, how it can occur, or where it is more likely to occur, or anything that you know about acute mastitis? Anyone? Thank you so much. So the most common cause is bacteria. That is the cause. And of the bacteria, the most common is Staph aureus. And that is gone. And then you have got something that is less common, which is a streptococcus. When you look at Staph aureus, because Staph aureus forms this fibrin, most of the infection of staph are localized. So you are going to have things like carbuncles, furuncles. Those are what are caused by this stuff. It is more localized. So even the inflammation, the acute mastitis caused by staph aureus, one thing that we need to know is that you are going to have normally a single. It can be a single or sometimes multiple abscess. This one we can just try to remember from microbiology. Staph aureus causes abscess formation. Okay, where you have got a region where you have got dead bacteria, and then you have got a dead immune cells, and then surrounded by this connective tissue, and that is basically local. But when it comes to strep, the infection of this guy is more generalized, like cellulitis, where the entire breast, when you look at the entire breast, we have a picture, you can see like here, this is cellulitis. You can see the entire breast has changed. It is erythematous. It is changed the entire. But then for the one caused by staph, you can see you have got an abscess. It's just localized. So this is the inflammation that can be caused by bacteria. One caused by staph, one caused by strep. Is there any contribution or question here before we go on? Okay. So when is this one most likely to occur? When is this acute mastitis likely to occur? So it mostly occurs in the first month of breastfeeding. So first month of breastfeeding. That is when this acute mastitis is more likely to occur. And the way it's going to present is that you are going to have a painful erythematous breast, and also there's going to be fever. So those things, remember we said most of these the infections that oh, actually this is not even infection, this is not even a benign tumor, but the presentation, what we need to know here is that there's going to be pain. As we already saw, the skin is going to be red, erythematous, and then there's also going to be fever. Okay, basically that. And how you treat it, because it is caused by antibodies, you simply give antibiotics. Okay. And after you give antibiotics, you also encourage the patient to express milk, to remove milk. You can stimulate the breast. And anyone that can help. Why do we think after you give the patient antibiotics, you ask them to express milk, or at least to push the milk, to cause milk to come out of the breast? Why do you think we do encourage the patient to do so? Anyone with a thought? Okay. So your yes, yes, please. Thank you so much. Thank you so much for that. I also saw another hand. Is it Dr. Chileleko? Okay, basically, as our doc has said, you want to push away the bacteria. That's why you want to stimulate milk to come out. And then you have got the duct. So the second type of inflammation is duct actasia. And for this one, it occurs more especially in the fifth and sixth decade, like 50 years, 60 years of life. And also, you are going to have nearly the same presentation, pain, and erythema, though the erythema is going to be uncommon, right? And another presentation is that you are going to have a palpable periareolar mass. Palpable periareolar mass. And this mass that is around the areola normally is going to produce a white like secretion, or a grayish white secretion. So you can see this one, this part here. So it's a mass that is palpable, and then there's this whitish production that is the ac- actasia. Okay, basically that. Another thing just that we can talk about is what is the cause. Anyone that can help, what do we think is the cause of the duct actasia? The cause. Okay, so what you are going to see is the cause here is basically an obstruction to the duct, or the duct has been destroyed, or maybe there is inflammation or fibrosis. So those are the possible causes of the duct actasia. Okay, and what you are going to see is that the nipple is going to be, sometimes there can be nipple invasion, and that can mimic, it can be appear as though it's cancer because the nipple has been invaded. As you saw, look at how it is. It is peri areola. If it invades the nipple, it mimics cancer. And then the granulomatous mastitis, this is a type of inflammation that is basically a manifestation of disease. For example, if someone has got TB, someone has got sarcoidosis, so it is basically a manifestation of disease. So that is inflammation. And then the second type of pathology you see with the breast are benign epithelial lesions. Benign epithelial lesions. Now, as we can see, these are lesions to epithelium, but they are not benign. Okay, they are not benign. When you look at the cancers of the breast, the cancers of the breast can either affect the ducts, you can see the ducts, or the lobules. That's how you can simply divide the cancers of the breast. Now let's start with the benign epithelial lesions. Now the benign epithelial lesions again can be divided into, we can put them into three many groups. The first group is going to be what we call the non-proliferative breast changes. So we as well call this as a fibrocystic change. And then the second type that we can talk about, this is non-proliferative. The next one is going to be proliferative breast disease. Now, the proliferative breast disease is of two types. That's how we are ending up with it. Three, as I mentioned. So number one, you can have without atypia, and then the second one is going to be with atypia. So let's start with the non-proliferative breast change or the fibrocystic change. Anyone that can say anything about the non-proliferative breast change? Anything? Just anything? So the first thing, please let's be free to speak. You know, when you speak, the more you speak, the more likely you are not to forget. Even if it is just saying something, just saying something. So the non-proliferative, even from the word, you have got a tumor, right? But this tumor is not dividing. That is non-proliferative. Okay. So number one is that what can cause this tumor? It can be hormonal induced. Number one, you can have hormonal, I can put it here, hormonal induced acinar hyperplasia. Hormonal induced acinar hyperplasia. So specifically, when you have got more of estrogen, what estrogen is going to do is that it is going to cause these tumors to start developing. Actually, estrogen is a major factor that disposes people to having cancer of the breast. Take note of that. So the estrogen can start making the acina, that end of the breast, these guys, this end of the breast, to start proliferating, to start dividing, and so you are going to end up having a lot of cells because there is hyperplasia. Okay, so that is the first thing we need to know there. And this is going to be common in between 20 and 40 years. So you have got different types of these non-proliferative breast changes. Now we are saying these are non-proliferative. You are These don't divide. Okay. The first thing is that there is a problem. Estrogen caused cells to increase in number. Now that they have done that, they are already a lot. They will not go on dividing themselves. That's why we are calling them non-proliferative. And you have got different subtypes of these. Number one subtype, you have got what we call a cyst. Now, a cyst is a dilatation of the lobule. Okay, as we said, these lobules will just end up dilating. And what is really the problem? What is a cyst? A cyst is basically a fluid filled sac. So these lobules are getting to be filled with fluid, and so they are ending up being what? Dilating. So that is a cyst, number one. So this guy, a cyst is going to cause, normally is going to be, it will cause some concern when it is firm on palpation. It is going to cause some concern there. But remember, they are non-proliferative. So simply because someone has got this cyst doesn't mean that they're going to have cancer later on. It is not, it doesn't correlate. Another type of this non-proliferative breast change is fibrosis. So what happens that when a cyst ruptures, is going to be surrounded by fibrous tissue, and that is fibrosis. Okay, and One thing we need to know about fibrosis is that it can lead to chronic inflammation. It's actually what is happening is that your the cyst had to rupture, and that led to chronic inflammation. The inflammatory cells are going to come in, and then you're going to have the fibers, the fibrins being laid. That's when you form this fibrosis. Fibrosis is basically having a tissue that has got necrosis, the tissue of dead tissue, and then you have got fibers. So besides cyst and fibrosis, you can also have what we call an adenosis. So when you hear adenosis, adenosis is just an increase in the number of these acina. Remember the acina? This. Let's say this is the normal. You have got like three acina there. And then in adenosis, what you're going to see is that this is known as a lobule. So now you have got, look at this one. What has happened? You have got a lot of acina in a lobule. So that is what we call adenosis. Basically, there is an increase in the number, not size, but number. Okay, so besides the adenosis, we also have what is known as the lactational adenosis. Again, I should mention simply someone has got adenosis doesn't mean that they are going to have cancer later on. It is not it is not one of those factors that show that someone is going to have cancer or a predisposition factor. Is there any addition or question? So lactational adenosis, this one is common in pregnancy or breastfeeding, where you have got a palpable mass. Again, it is not associated with increased risk of breast cancer. Any addition or any question? Okay. Now we go to the proliferative breast disease. We have got those with atypia and those without atypia. Now, when you're talking about atypia, remember these are proliferative, and you know that cancerous cells do divide, isn't it? So, meaning that these ones, the proliferative breast diseases, have got some chance of becoming a cancer later on. That's why we're calling them proliferative. So those without atypia, atypia is meaning they are having characteristics of cancer, of being malignant. So those without atypia, they don't have the characteristics of a cancer. So what are the examples of proliferative breast diseases without atypia? An example we can mention is just the hyperplasia of the epithelium. Okay. So epithelial hyperplasia. So simply because epithelium is dividing and dividing doesn't mean it is a cancer. Okay? Epithelial hyperplasia. Besides that, you also have adenosis, but not the this one that is here. We have got what is known as sclerosing adenosis. Okay? So those. And also a papilloma. You know, a papilloma is just these finger like projections. Now, the proliferative breast disease without atypia is a predict, predictor. When you have got these conditions here: papilloma, sclerosing adenosis, or epithelial hyperplasia. It is a predictor of risk, but it does not mean that someone is going to have cancer later on. It is a predictor. If you leave it like that, well, come some time later on, when someone has grown, they can have a cancer. It is a predictor of risk, but unlikely to be a precursor. Please, it's not a precursor of cancer, but a predictor. And then for the proliferative breast disease with atypia, this is now having some, not all, take note of some histological features that are diagnostic of carcinoma. Okay, that's why we're saying with atypia. So some features diagnostic of carcinoma there. So what are the examples that we can mention of proliferative breast disease with atypia? We can talk of atypical ductal hyperplasia. We had the normal hyperplasia, epithelial hyperplasia, but you also have atypical ductal hyperplasia. So you just see the ducts are now increasing in number, and their cells are showing characteristics of a cancer. Okay. You also have what we call atypical lobular hyperplasia. Remember we said that cancers can develop either in the lobule, this is a duct, or in the lobule. So on the proliferative without atypia, you have got ductal hyperplasia or lobular hyperplasia. And then when you go to with the atypia, you basically put atypia in front. Atypical ductal hyperplasia, atypical lobular hyperplasia. So when you have got those without atypia, they can lead to those with atypia. Those with atypia, now these guys have got a risk. So if someone has got atypical ductal hyperplasia, that is a risk. Later on in life, they can actually develop a cancer. Remember the one without atypia, we said that it is just a predictor, but it doesn't mean that someone is likely to have cancer later on. Because some questions that you are going to find in essays will be write about the risk factors for breast carcinoma. So these proliferative breast diseases with atypia, they are risk factors. Is there any addition to this before we go to the actual cancer and then we get to finish? Any addition or question? Okay. So before we go to even the actual cancer, let's talk about just two things: gynecomastia and fibroadenoma. Remember of what we mentioned here for the non-proliferative breast changes. Can you see that we had adenosis and we also had fibrosis? So sometimes we can combine adenosis and fibrosis. That forms the fibroadenosis, meaning that you're having fibrous tissue at the same time there is adenosis, there is increase in number. All right. So basically that the combination of those two, and it's actually the most common. Now let me not rush ahead of myself. Let's mention just something about gynecomastia. Anyone to help us? What is gynecomastia? Anyone? I know we know something about it. Thank you so much. Thank you. So, enlargement of breast in males specifically. And it is important to understand that the cause is imbalance. Please, not high. So it is an imbalance of estrogen. Take note of that. Estrogen imbalance, not high estrogen. Because normally in males, we know that males, we have got androgens like the testosterone. So what happens that when you have got high estrogen, you are supposed to have high androgens also, because these estrogens are promoting the development of breast. Androgens counter that effect. So if you have got high estrogen and high androgens, you might not have this gynecomastia. But if there is an imbalance, there is a rise in estrogen without a rise in androgens, that's now going to result into gynecomastia. And what are some of the causes of gynecomastia? So you are basically looking at factors that can lead to an increase in estrogen. So one thing that we can think of is that estrogen is produced in the liver, not produced in the liver, but estrogen is going to be broken down in the liver when it is produced. So meaning that if someone has got liver disease, liver cirrhosis, it means that there is no place to be able to destroy the estrogen. So it is going to be able to, there's going to be imbalance, and that can cause gynecomastia. Anyone that can cause that can give us any other cause for gynecomastia? Anyone? Alcohol consumption. Thank you so much. Anything else? We know also alcohol destroys the liver, right? So we can also relate like that. Anything else? Also old age. Okay. So what happens is that when the older a male is, there's an increase in estrogen, because the androgens from the from the testis, they reduce in production. So really, old age is not because you are producing more estrogen. It's because there is a reduction in the production of androgens in the testis. So that is why there is that imbalance. Okay. And also, as we have said, drugs like alcohol, you also have marijuana, the most abused illicit substance. And also the treatment for HIV, ART, and retrovirals. So these guys also are a factor that can lead to gynecomastia. Of course, rare, you also have conditions like Klinefelter syndrome, testicular cancer, especially let's say Leydig cell or Sertoli cell tumors. So these also can predispose to having gynecomastia. So for someone that has got gynecomastia, when you look at the histology of the breast, remember this is pathology where we should understand more of the histology parts. You are going to see there's going to be increase in dense collagenous connective tissue, increase basically in collagen. Okay, and this is associated with hyperplasia of duct. So the lining or the ducts are also going to start increasing in number. Plus the collagen that has increased, that is making the breast to become big. And having gynecomastia is actually going may be associated with a risk of having cancer of the breast. Okay, and then about the last thing before we mention the cancer is what we are calling as fibroadenoma. As we said, this is a combination of the fibrous or fibrosis and adenosis, as we saw in the non-proliferative breast changes. Anyone to say something that they know about fibroadenosis? Anything? One thing that we should know, please, this one don't forget, it's a most common tumor. It's a most common benign tumor. Please never forget. Most common, it's not malignant, it's benign. Remember, we've just combined fibrosis and adenosis. So it's the most common benign tumor of the breast. And this tumor is actually biphasic. Anyone that knows the meaning of this word biphasic to help us? Anyone? S- So when we say biphasic, remember the breast has got stroma, which is a supporting tissue, and then epithelium. So this tumor is associated with both neoplastic stromal cells and epithelial lined glands. So the epithelium and the stroma are both affected. And when you look at the stroma is going to be more cellular. Please, you should take note of that. The meaning of more cellular is because there is much proliferation that is happening. And besides that, the stroma, remember, is supporting tissue. So the supporting tissue is having a lot of cells and it is abundant. Okay? So take note of that. And then what you are going to see is that the stroma is going to form projections which will look like leaves. But that will be specific for another condition that we are going to mention. But just take note that biphasic means affecting both the stroma and the epithelium. So what are some of the things that you'll be able to see from the fibroadenosis? Fibroadenosis is frequently multiple and bilateral. So we're going to see it both sides. So you are not just going to see one part that has fibrous tissue with adenosis or increase in number, but multiple and bilateral, affecting both sides of the body or the breasts. And besides that, for a fibroadenoma, you are going to see that in young women, you are going to see a palpable mass, while in older women, the breast is going to be mammographically dense or calcified. You can tell using a mammograph or mammogram. The breast is dense and it is calcification. Calcification just means becoming hard. The deposition of calcium. You know, calcium makes a bone hard. So the morphology, how are you going to tell that this is fibroadenosis? When you talk about their size range from 1 centimeter until they become very big, such that they cover the entire breast tissue. So the entire breast tissue is gone. Other features that I don't want you to forget about fibroadenosis is that besides them being ranging in size, they are well circumscribed. Like you can tell their margins. circumscribed. Besides that, it is a grayish white nodule. Okay, that will be the appearance. And then besides that, when you look at the skin where you have got fibroadenosis, there is a bulge above the surrounding tissue. And besides that, fibroadenosis is described as a rubery. The meaning of that is that it is dense and firm. Okay, the tissue is dense and firm. Remember, you have got fibers, so that's why it is dense and firm. Besides that, the stroma is often delicate, so it is going to resemble intralobular stroma. Okay, it is resembling intralobular stroma because this guy is actually going to be affecting. Remember, this is our breast. This is supporting tissue that is between these lobules. That's what will resemble this fibroadenoma. So the fibroadenoma resembles the intralobular stroma. So that is about a fibroadenoma. If you can just look at a picture, that's one. You can see how it is looking. And for the tissue, you can see, you can't really tell the acina. Most of it you can see you have got the fibers and then also the proliferating cells. And then you can see the whitish appearance on macroscopy. Just one thing else that we need to know is what is known as the phyllodes or phyllodes tumor. It is also a biphasic tumor, just like the fibroadenoma. Another thing that we need to know is that it is much less common. The most common benign tumor that we mentioned is a fibroadenoma. And where does this guy arise? It arises from intralobular stroma. So the stroma surrounding the lobules, intralobular stroma. And it can occur at any age, but more common in the schisters. And normally it is going to be associated with clono-acquired chromosomal change, specifically on chromosome number 1. So I've got a gene there, so chromosome 1q. So this change, if there is a change on this chromosome, that's what this one is associated with. And why is it called the Phyllodes tumor? Phyllodes just means leaf-like. Can you see the way this is looking like? So you are having the structure going, you are having these infoldings of this epithelium, and that's forming like leaf-like structures. So when you look at the morphology, it can as well vary in size, starting from a very few centimeters to reaching to a point where it covers the entire breast. It has got a leaf-like architecture, and then you are going to have proliferating stroma. Okay, the supporting tissue is going to be dividing and dividing and dividing. Of importance is how can you differentiate a phyllodes tumor from a fibroadenoma? Anyone that can mention anything? How can we differentiate this guy from a fibroadenoma? Anyone? Okay, so when you look at a phyllodes tumor, it has got a higher cellularity. You have got more cells because there's high cellularity, and then there's more mitosis, there's more division than the fibroadenoma. Besides that, there's also stromal outgrowth. So you can see the stroma growing, coming out, going in, coming out like that. And then besides that, there is also infiltrative borders. Infiltrative border. And you can tell from the picture, these borders are going in, that's to infiltrate. Okay. Mitosis is causing the stroma to overgrow. Besides that, when you look at the nucleus of the cells histologically, there is nuclear pleomorphism. Different sizes of the nucleus and different shapes. Nuclear pleomorphism. So these are the things that will differentiate phylloides tumor from the fibroadenoma. And now the last thing that we need to know, that is now that we have understood this, the actual cancer. Okay. So we also have this thing here. It's a papilloma. We already did mention it. It's also one of those benign lesions. So for a papilloma, can you see you have got a leaf-like, not leaf-like, but you have got a structure that is making like a finger. And can you see this thing that is going in like that? So it has got a point where it is attached to the other epithelial tissue. So is going to is basically a growth within a dilated duct. Okay, just a growth there. And it is composed of multiple branchings. That's why we call it papilloma. You are going to see more hands like that. Now, these papillomas can affect large ducts or small ducts. For large ducts, as we said, these are basically the sinuses. You can see the lactiferous sinus before you can drain at the nipple. So the large duct papilloma is situated on the lactiferous sinus of the nipple. Okay. And it is usually solitary. The meaning of that, it is usually alone, like you can see. Large duct papilloma. And then the small duct papilloma, these are usually multiple within ducts. Okay. And the majority of them will be able to produce a discharge. Like 80% of papillomas will produce a discharge, and then others will produce blood, especially if this stalk here undergoes torsion. Okay, like it rounds about itself, it will produce blood. And some of the papillomas will be able to produce a serous discharge, and that can lead to blockage and release of normal breast secretion. So it can lead to a blockade. Okay, so that's about a papilloma. Now the carcinoma itself, which is the breast cancer itself. Now breast cancer, the first thing that we have already understood the thing. So here it is real quick. We are basically looking at the risk factors and the classification, and then we are done. Let's talk about risk factors. What are some of the things that poses someone to having breast cancer? Some of them we've already talked about them. Anyone? Number one, factors to getting breast cancer. Anyone? Thank you so much. Hormonal exposures, number one, so that we will not be wasting time. Do you want to explain this point? You can be free in case you want to explain it. So we know that the increase, when you have got specifically hormonal exposure, high levels of estrogen is going to be associated with an increased risk of cancer, breast cancer. That's hormonal exposure. And then drugs that inhibit the receptor for estrogen are going to lead to the reduction in the chances of getting this cancer. What are the examples of those drugs? For example, tamoxifen. It's actually a drug that we also use for the treatment of breast cancer. This guy binds on the receptor where estrogen is supposed to bind, so it acts as an antagonist. You also have drugs that will prevent the production of estrogen. Those also will reduce the risk of getting breast cancer. So that is on the hormonal. Anyone else? Number two, any other factor, risk factor for getting cancer, breast cancer to be specific? Inheritance. Yes. Oh, thank you so much. So genetic predisposition, right? Genetic predisposition. So you have got a lot of genes actually that are going to be associated with the cancer if they undergo a mutation. Majority, 80 to 90% of those cases are going to be two genes. We call them breast cancer genes. Breast cancer gene 1 and 2. These are going to be associated with 8. So if someone has got, now this breast cancer gene actually protects a person from getting breast cancer. If there's a mutation with this gene, it disposes a person to getting cancer. Now, besides getting breast cancer, these two genes are also going to predispose someone to getting ovarian cancer. If it is in a male, getting prostate cancer if there is a mutation. So breast BRCA gene 1 is found on chromosome 17, 2 is found on chromosome 13. So these genes are actually involved in correcting mistakes that happen when to the double-stranded DNA. Remember, let's say there is replication and that leads to some form of changes to the double-stranded DNA. So these genes are the ones that help in correcting those mistakes. So if they are mutated, they will not correct those mistakes. Okay. So these are the genes here. And okay. So basically that we can go to another factor. Number three, anyone? Thank you so much. So radiation exposure. For example, if someone is having a chest irradiation, maybe they have got a cancer as a form of treatment, so that is also going to result into an increased risk of getting breast cancer. Number four, anyone else? Even gender, right? So greater in females than in males. Okay. Obviously, because of the estrogen being higher in the females than in males. Number five, anyone else? Any other risk factor? Also race. Yes. Okay. Race is also going to be a factor that is going to contribute to having this genetic factor. So when you look at the African Americans, those are going to have an increased risk of getting breast cancer. Okay. Besides race, also geography. So race and the geography. Okay. So when you're talking about geography, people that are most likely to have breast cancer are those in developed countries. And the reason for that we'll talk about it as another reason. Developed country people, these guys are educated. They don't want to marry. They don't want to have children. They don't want to breastfeed. Even when they have got children, they would rather get a nun to be breastfeeding. So all those, we are going to see the importance of you breastfeeding. Anyone else? Any other factor that is a risk factor for getting breast cancer? Anyone? The age. Thank you. Thank you so much. So age is actually proportional to the incidence of to the risk or to predisposition to having breast cancer. And specifically, two important things that we can talk about age is the time when someone is starting their menarche and when someone is ending, that's menopause. So let's say someone started their menses at 15, they finished at 55. So this person, or normally most of them finish at 45. So this person has got a fertile period of 30 years. Now let's say someone started early, let's say at 10, and then ended up finishing the menses, let's say at 55. They have got a period of 45 years when they are fertile. And in the period of fertility, what is happening is that you are producing estrogen. And the higher the estrogen, the more you are likely to have the cancer of the breast. Okay, so reduction in the age of menses and increase in the age of menopause. These are the factors that will lead to having a higher risk of getting breast cancer. Okay, we can go to number six. Sorry, number seven. Any other factor? Anyone? Even diet. Okay, diet. Like when you consume large amounts of for the diet, a diet that is rich in fat, high calories, cigarette. Of course, that's not food, right? But you can put it there. Also, alcohol. These are these are factors that can increase risk of getting cancer. And when you look at fat, we can also talk about this one only. Another factor, which is obesity. So what is going to happen is that women that are less than 40 years are going to have a low risk of getting cancer than those who are much older, because the older people get, the more the fat, because fat tends to replace most of the tissue. So for postmenopausal obese, they are postmenopause and then they're obese, they have got a high risk of having cancer. And that is because estrogen is going to be synthesized in the fatty droplets. That is why the obese and then their postmenopause have got a higher risk. Okay. And then number nine, any other factor, risk factor? Okay, another factor is reduction in breastfeeding. Reduction in breastfeeding. So when someone is breastfeeding, let's talk about that 40 years that, let's say someone started the menses at 15 and then they finish at 45. So they have got 30 years of producing estrogen. When someone is breastfeeding, that time of breastfeeding, they'll not be producing much estrogen. So that reduces the period of them producing the estrogen. And estrogen, since you have reduced their period of production, you have reduced the risk. That gives us another factor also, pregnancy. Okay. So someone that is pregnant has got reduced estrogen because you are producing more of the progesterone than the estrogen. So meaning that the nulliparum have got a high risk of having breast cancer than the multipara. Well, if you're not breastfeeding and you have not had a child, you have got a higher risk of having breast cancer. Number 11. Anyone else? Any other factor? Exercise. So those who exercise have got a reduced risk of getting cancer than those who don't exercise. And then number 12, also we can talk about breast density. For women that have got a very high density of the breast, they have got an increased or a higher risk of getting breast cancer than those who have got a low density of the breast. Besides that, family history is a very important one. Family history. So we have got what we call first degree relatives. First degree relatives, if they have got a cancer, you are more likely also to have the cancer, like your sister, your mother, especially, especially if your first degree relatives got the cancer at a lower age. Like, for example, your mother had the cancer while they were 12, 13, 14, 15, 20, than when they got the cancer when they were old. Because when you get a cancer when you are very young, it means that obviously you might be having some genetic factor like the same BRCA gene. Okay. So any other factor that someone is thinking of? Okay, we can also mention the fibrocystic change. Okay, especially when it is associated with atypical epithelial hyperplasia. Remember we said that the atypical epithelial hyperplasia, those were risk factors for getting the cancer also. And also another factor that is a risk is cancer of the contralateral breast. If someone has got a cancer of the other breast, more likely even the other one. Besides that, also the environment is also a factor that cause can put someone at risk. Specifically in the environment, like those who are exposed to the organochlorine pesticides. These ones have been associated with an increased risk of getting cancer. Okay. I think these are a lot that we can mention for now. So you can see the clinical presentation of breast cancer. Anyone that can mention anything, let's finish up. Anyone that can mention anything that they can see here. So this one has got breast cancer. What can you see? Anyone? Breast enlargement. Thank you. Anything else? There is nipple retraction, as you can see there. Yes. Anything else? So irregular shape. Okay. So other things that we can see is the mass or the nodule is normally penniless and then it's hard and it is fixed. What is known as puckering fixation, like it is held to the underlying skin, you can't move it. And then there can also be edema and lymphadenopathy. Those are preclinical presentation, like the axillary lymph nodes. When you are talking about this cancer, what is the cause? So you can see someone has got a normal duct, it starts to proliferate. So there is now hyperplasia, the cells are dividing, and then that can lead to dysplasia. So we're going to have carcinoma in situ. So when you're talking about cancer, you can divide it like this. Okay? Breast cancer can be non-invasive, meaning that it is localized, it doesn't go anywhere, and invasive. The non-invasive is also known as carcinoma in situ. It can affect the ducts or it can affect the lobules. The invasive cancer as well can start from the duct or from the lobules. So you can have ductal carcinoma in situ, you can have lobular carcinoma in situ, and like that. So you can see here we have got carcinoma in situ. It is not yet invasive. So it started as hyperplasia, it became the carcinoma in situ, which is not invasive. And then it can now become ductal. You now have the ductal carcinoma in situ. This was just carcinoma in situ, just a dysplasia. Now it's affecting the ducts. And then now it can start invading the cells. So it now becomes invasive. That's how you end up with the cancer. That is the etiology. And when you look at this breast cancer, it can either be familial, like it is running in families, or it can be sporadic. It just happens, you don't even know why it has happened. The sporadic is caused by those other factors except the genetic, which causes the familial. And so the last thing is how we classify the cancer. You can use different methods. One is the one we are just from mentioning, the carcinoma in situ and those. Another one that you can talk about is looking at what we call molecularity. So the molecular classification. So molecular classification, you are looking at the cancer, what type of receptors are present on the cancer. Okay. So in that way, you can divide them into lumino A, lumino B, and then you also have the triple negative, also known as basal-like, and then the third one. Anyone to remind me the third one? The third classification of molecular classification of the cancers of the breast. No one. Pardon? I didn't get that. Oh, okay. Okay, I believe we'll get it as we go on. So when you're looking at the molecular classification of breast cancer, what you're basically looking at is the receptors. So you have got three main receptors. You have got what we call the estrogen receptor. So when you start with this one, the lumino A, these guys have got estrogen receptor on them. So we say they are estrogen receptor positive. They also are progesterone receptor. So they are progesterone receptor positive also. Besides that, these guys, there's also another receptor, the human epidermal receptor 2. That's the HER2. So for this receptor, these guys are negative. Okay. And then for lumino B, you have got estrogen receptor positive, also PR positive. Now the HER receptor can either be positive or negative, depending. For the triple negative, even from the word, this one, all the receptors are negative. Okay, sorry for that. So for the triple negative, all the receptors are negative. It's also known as basal-like. So the importance of you knowing this is because, like for this guy, you can see this one. The re- the lumino A, since it has got estrogen receptors on it, the cancer has got estrogen receptors. It has got progesterone receptors. It has got her. It doesn't have R receptors. So what you can do is this one you can. When he was teaching, he said at least just know this one. You can use the drug tamoxifen for this one. And why are we using this drug? It's because this is an inhibitor for estrogen. So because these cancers have got estrogen receptor, tamoxifen can come and bind on these cancers, and then you'll not be feeding them with estrogen. And when you're not feeding them, they'll not be able to continue growing. So that's why you can. That's why it's important for you to understand this classification. Okay. The other one I forgot is known as HER enriched. HER2 enriched. So for the E2 enriched, they are positive for the R2 gene, they are negative for the others. This one is negative for everything. That's what you need to do. So the lumino A is also known as low grade, lumino B is high grade. Lumino A has got a good prognosis. You can treat it well and then you are done. But the others, they've got poor prognosis. That's one thing that we should be able to know about this. There's also what is known as the Ki-17. It is a tumor marker. So when you look at lumino A, this one is going to have less than 14% of this tumor marker. So meaning that it's not really bad. For the rest of these cancers, they have got Ki-17 greater than 14%, meaning that they have got high amount, can take up more of the tumor marker. So that is what is going to even more differentiate lumino A from lumino B, the Ki-17. And that is what marks the end of uh, these cancers. Just take note of Paget's disease. This is just a rare disease of the nipple, and it's a manifestation of breast cancer. So you have got cancer from the acini, and then it will be able to spread through. It is spreading from the beginning here, and then it ends up showing on the nipple without passing through the ducts, without crossing the ducts, without crossing the basement membrane. Okay, you can see these are the ducts involved in ductal cell ductal carcinoma in situ. and then the cells are going to be going like that. They will not penetrate the basement membrane, they'll end up coming out there. So the diagnosis of breast cancer, you use the triple test clinical method, and then you are going to also use imaging. The imaging, that's why you can do ultrasound for the young, or mammography for the old greater than 40, 35. You can as well now do biopsy. Okay, you can do the biopsy, and the biopsy is specifically for cytology. You can as well also do histology. The triple test is this: biopsy, specifically fine needle, and then you have got the clinical, where you've got history and physical exam, and then you have got also ultrasound or mammography. You can also use the special stains like these special molecular tests to see if you have got the HER, the ER, or the PR, or you can detect the gene, the BRCA gene. So these are essay questions that I found. A 34-year-old woman is recently diagnosed with breast cancer. What are the risk factors of breast cancer? Clinical presentation of breast cancer. What is the approach in investigating a breast lump? I think we've talked about all of these. Maybe just the should we answer or not? We've already talked about them, isn't it? Should we answer or not? Or we can go and answer since we've talked about them. Anyone to say something? Okay, we have already done. And then we also have this one. We already also did answer them. So these are the ones that you can just try to answer because we've already covered. And we end here for today. We'll continue with past papers tomorrow. I'm going to forward them again, but they are also there, but I'll send them.